Well, good morning, everyone. I remember when we started doing sputum work, my research coordinator, when I hired her, she's actually a research nurse, told me, I'll do everything but spit. And now we're doing sputum induction, and she's okay with it. So thank you, Diego, for putting this together. Dr. Maselli has always been resourceful in his topics, and I think it is a timely topic to talk about biomarkers. We did, for those of you who came at early morning at 6, thank you for coming, but we did talk a bit about biomarkers, but I promised to talk more about them today, and my task is going to be a bit tough because I only have 15 minutes, and I will try to stick to that, and my chair will kick me out if I take more. I do have some disclosures, none of which I believe will affect today's talk. My learning objective is how do we think differently about severe asthma using the biomarkers, and how do biomarkers help us identify the right person for the right treatment for the right person. So we know our understanding of asthma has definitely changed from thinking about it as a one-size-fits-all disease where eosinophilic inflammation is the classic pathway, to showing that yes, eosinophilic inflammation is important, but it can be more heterogeneous. And we know now that at least a couple of mechanisms that can lead to T2 high asthma through Th2 mechanism, with allergies being some of the main drivers. But we also know that there are some patients with T2 high asthma are non-allergic, where eosinophilia plays a major role, but here innate immune system drive the mechanism of this type of asthma. But we also know that about 40% of asthmatic don't have T2 high asthma, and these we can struggle either calling them non-T2 or T2 low. Either they don't have any inflammation in their airway, or they have neutrophilic type of inflammation driven by other cells like Th17 and other cytokines. So therefore, we have to keep that in mind when we talk about biomarkers. We would like to see biomarkers that can help us identify one versus the other, and hopefully try to help us delineate this disease more efficiently. Certainly right now, this is the era where we look at this disease and any other disease as looking at phenotypes. We look at endotypes and what drives the disease and the mechanism, and certainly genotype. I'm not talking about it today, partly because I'm not a geneticist and I try to avoid that 100%, but it's important. But biomarkers play a major role, and there are several emerging ones, some of which have been there for a while, which is what we are more familiar with. So why is it important? Well, even GINA addresses biomarker in the latest reiteration, and I won't go through this busy slide, but just to show you that they've used biomarkers from clinical trials to identify who would respond to which biologic. We'll talk more about it as we progress in the talk. But what is an ideal biomarker? An ideal biomarker is still not there, by the way, for asthma, but we have few. But ideal biomarker should be actually reproducible, should be done at the point of care in the clinic, should give us an idea that this patient has the disease and possibly can have a prognostic properties, but also predictive properties, and more importantly, pharmacodynamic properties, meaning the biomarker would go down as disease is controlled. And it should be obviously cheap to test. So how is it for asthma? Well, we have diagnostic biomarkers right now, mostly the physiologic biomarkers, predictive biomarkers that predict response, and then we would like to see biomarkers that have prognostic effect so that they can tell us this patient is at higher risk of increased risk of exacerbation. What do we have? Well, the platform of biomarker is pretty big. Obviously, we're not going to deal with each one of them today, but my task is really to deal about the sputum and blood biomarkers. Dr. Maselli will talk about FeNO, which is very important, but there are other exhaled air biomarkers that are being looked at or have been tested. And certainly you can see urinary biomarkers are emerging, as well as the gold standard are bronchoscopy and biopsy, which we obviously know it's gold standard, but it's very hard to use in clinic. So eosinophils, these are the cells that really propagate majority of patients with T2 high asthma, and through different mechanisms that I already talked about have been looked at as biomarkers both in sputum and in blood. And many of the proteins of eosinophils are now being looked at as biomarkers, but also in blood, but also in spit. And so eosinophils are important, we know, in propagating this T2 high asthma. They can be associated with increased hyperresponsiveness, remodeling, may be associated with increased airflow obstruction, and they release granules, which actually are the proteins that we can actually test in some blood or in the serum or sometimes in the sputum. And there are associated cytokines that are linked to eosinophil inflammation. The very first group that looked at whether we can use sputum eosinophil in allowing us to manage patients with asthma are the British, and Dr. Green here has shown that if you do induce sputum and check eosinophil and titrate inhaled steroid based on eosinophil, it's actually better than just using your gut feeling, using management guidelines by the British Thoracic Society. And this has actually been replicated by several studies. In fact, there is even a Cochrane meta-analysis on this showing that in these 3 studies, the using sputum eosinophil to treat patients with escalating inhaled steroid is a better way than using guidelines or clinical measures. We also have recently seen a paper, Sienna study from the ACRN group, which looked like sputum eosinophils were in patients with low sputum eosinophil with mild asthma, showed no difference in response between inhaled steroid and long-acting anticholinergic. So absence of sputum eosinophil may sometimes be helpful in helping us to see if the patient needs an inhaled steroid or not. Well, that's well and good. And I think if my friend Param Nair from Hamilton was here, he would be fighting with me now because he loves sputum testing. But let's face it, it's not a very practical way. You have to induce it. Patients can get bronchospasm. You have to have a good lab. And a sputum eosinophil more than 2%, 2 to 3%, is suggestive of eosinophilic asthma. But even the guidelines, ATS-ERS guidelines, suggest that peripheral blood eosinophil may be a surrogate to sputum eosinophil. And in fact, the NIH biomarker panel suggests to use this as a supplemental biomarker. Do we have evidence? Yes, there are quite a bit of papers showing that there is a good correlation between blood eosinophil and sputum eosinophil, and actually that correlation improves if you use FeNO level as well in this study where total IgE was not a predictor of sputum eosinophil, blood eosinophil and FeNO were. We also know that blood eosinophil are good prognostic biomarkers. They have been shown, this is a real-world study from the UK looking at the increased risk of exacerbation and respiratory events. The higher the blood eosinophil, the more risk of exacerbation and poor asthma control. We also know that when you look at blood eosinophil and FeNO, and Dr. Maser will talk more about FeNO, you actually can identify patients at high risk of airway hyperresponsiveness here on the left, and higher risk of exacerbation. So maybe composite biomarker in the future would be the way to go rather than just using one alone. So where do biomarkers, at least blood eosinophil, help us? Well, in identifying patients who respond to anti-IL-5, for example. In the Mensa trial, this has been clearly shown that the higher the blood eosinophil at baseline, the better effect on exacerbation reduction using an anti-IL-5 agent here, mepolizumab. This has been also shown that blood eosinophil with this type of therapy can act as a pharmacodynamic biomarker, where blood eosinophil can go down significantly after initiating therapy. This has been shown also with benralizumab. So it's not just unique for mepolizumab. With all anti-IL-5 agents, you can see a very similar effect. We also have seen that blood eosinophils can be good predictors of response to an anti-IL-4 agent, dupilumab. This also has been shown in the QUEST study, as you see here, where patients with high blood eosinophils, but in the same study also high FeNO, was a good predictor of response regarding exacerbation reduction and also lung function improvement compared to those with lower eosinophil, less than 150. And we also looked at this as a predictive response to omalizumab in our clinical trial extra. We found that also patients with high blood eosinophil and high FeNO may have a better effect on reduction in exacerbation with an anti-IgE agent. And these are the data that Gina recently used in pointing out some recommendation. Although I have to point out in real life study like this, Prospero, with omalizumab, which is an anti-IgE, as you all know, blood eosinophil at baseline or FeNO at baseline did not really predict who would have response to reduction of exacerbation. So what do we know about blood eosinophil? Well, it's good. I think it's cheap. You can test it. But you have to be careful. There's quite a bit of variability day to day or even within one day between morning and night. So Gina recommends at least 3-time measurement consistently before you call a patient with eosinophilic asthma. It can be affected by several things, as you see here, and also several comorbidities. Finally, what about blood IgE? IgE is important. And actually, probably total IgE is not as important as allergen-specific IgE, which is actually important to delineate allergic phenotype of asthma. But we also can measure it. It's not point of care. It has to be sent to the lab right now, although there are some attempts to do it as point of care. But I have to mention that IgE, total IgE, can be also affected by age. The level does not itself predict response to anti-IgE, but it has to be high to qualify a patient for omalizumab. But the level of IgE itself is not a good prognostic indicator or predictive indicator. Allergen-specific IgE is an important biomarker in the presence of symptoms of allergies to designate a patient with allergic phenotype. And as you see in this slide, usually high IgE constitute in the presence of other biomarkers T2 high asthma phenotype. There are other emerging biomarkers. We recently have reviewed this. This is a paper that Dr. Narendra, who's in the audience, and I wrote, and it's still in review, but hopefully get published soon. There are several others, serum and sputum biomarkers. We didn't talk about sputum neutrophils because there's quite a bit of controversy on this. But in general, 60% or more sputum neutrophil may suggest in the presence of severe asthma and neutrophilic type of asthma. So my take-home message is that we have come a long way with biomarkers, at least in the blood. The sputum biomarkers certainly may be better, but they're harder to define. And I think our understanding in splitting this difficult asthma into multiple phenotype is very important. And without point-of-care testing and biomarker, it's very, very hard to do. I think we have good biomarkers for T2 high asthma, more to come, but what we need and where there is an unmet need are biomarkers in T2 low or non-T2 asthma, and I think that's something needs to be done. And there are attempts to look at composite biomarker, more than one, which may actually help better identify these phenotypes so that we can pick the right treatment in the future. Thank you very much for your attention.